Happy New Year, everyone. Welcome to the IARS Virtual Education Webinar, Challenges in Managing Diabetic Patients, SGLT2 Inhibitors, GLP1 Receptor Agonists, and Insulin Pumps. My name is Sakura Kinjo. I'm an anesthesiologist at University of California, San Francisco, and I'm moderating this webinar. Next slide, please. Thank you, IRS, for organizing this webinar. This webinar has received no commercial support. Next slide, please. Annual meeting is coming up and presented by IARS and SOCA, May 17th to May 19th, and beautiful city, Seattle, Washington. Please save the date. Next slide, please. And also for the annual meeting, late-breaking abstract submission is now open. Submit your late-breaking abstract for the opportunity to present your research at the annual meeting. For more information, please visit the link presented here. Next slide, please. And if you missed the 2023 annual meeting, on-demand recordings are available for IARS members. And please visit the link listed over here. And next slide, please. And IARS has a very active Doc Matter community. The speaker will be available for questions and comments. And then we continue this discussion in the IARS member community. Please go to docmatter.com/IARS or use a QR code here. Next slide, please. Okay, there are a couple of upcoming webinars. In February, what's new in pediatric emergency delirium? And also in March, AI and machine learning to predict intensive care unit indices and outcomes. Next slide, please. And regarding Q&A, please use the Q&A button on the Zoom taskbar to submit questions. Next slide, please. And let's get started. So the first speaker is Dr. Gupta, and then he's discussing about SGLT2 inhibitors. And let me introduce Dr. Gupta. Dr. Gupta is currently an assistant professor in anesthesiology at the University of Chicago. He completed residency training in pediatrics and anesthesiology and fellowship in pain medicine. His clinical interests are similar to mine, regional anesthesia and ambulatory anesthesia. And Dr. Gupta and I have worked in the committees in national organizations such as ASA or Society for Ambulatory Anesthesia. His research interests include outcome research using hospital electronic medical records and the publicly available national and state database. And next speaker is going to be Dr. Robert Rushakoff, and he is an endocrinologist and professor at the UCSF. He is the medical director for inpatient diabetes. Dr. Rushakoff has numerous publications in this area, and actually he's the to-go person for us if we have any questions about the management of complex diabetes patients. He has pioneered internet interactive mandatory training for physicians, nurses, and pharmacists. He continues to introduce new innovations on all areas of inpatient diabetes management, including the virtual inpatient diabetes service and automating insulin dosing. And he was a member of the Endocrine Society Committee, writing new guidelines for inpatient diabetes management. The practice guideline was published in 2022, and it has been widely adopted. And let me introduce the third speaker, Dr. Girish Josh. Dr. Josh is a professor with tenure, Department of Anesthesiology and Pain Management at the University of Texas Southwestern Medical School in Dallas, Texas. Dr. Josh has published numerous articles in many high-impact journals. He has been an invited speaker at many national and international conferences. He is an executive editor for Anesthesia and Analgesia and the section editor for Up to Date. He is the past president of the Society for Ambulatory Anesthesia, the Society of Anesthesia and Sleep Medicine, and the Texas Society of Anesthesiologists. Related to this topic, he is the first author of ASA consensus-based guidance on preoperative management of patients on GLP1 receptor agonist, which was published in June last year. I'm very excited about this webinar, and let's get started. First speaker is Dr. Atul Gupta.
Next slide, please. Next slide, please. So this is the outline that I'm going to be talking about. What are SGLT2 inhibitors? Why should we care? How should we manage the patients who are on SGLT2 inhibitors? And the conclusions. Next slide, please. So what are SGLT2 inhibitors? These are osmotic diuretic agents which were initially approved just for diabetes treatment, but their use has expanded over the years. They are also commonly pronounced as SGLT2 inhibitors of flozins. And just to clarify, SGLT2 inhibitors are not like GLP1 agonists. And the reason I bring this up is that there is a common misconception amongst, at least amongst the people I've talked to, amongst many anesthesia providers, and they confuse SGLT2 inhibitors with GLP1 agonists. They have no direct effect on gastric emptying. Next slide, please. So SGLT2 is a co-transporter of sodium and glucose. It is located at the proximal convoluted tubule cell, and the function of SGLT2 transporter is to transport sodium and glucose into the cell. And these inhibitors essentially impair the action of SGLT2 co-transporter and cause increase in glucose excretion. Next slide, please. The effect of SGLT2 inhibitors is insulin independent. They lower hemoglobin A1C by about 1% and a weight loss of about 3 kilos. Next slide, please. They have effects on other organ systems. They have pleiotropic effects. They improve outcomes in heart failure. They also slow decline in GFR. Next slide, please. These are the commonly used medications they're all flozins. I won't go into details about each of the indications, but these are FDA-approved indications. And some of them are approved for use in improving cardiovascular disease outcomes with or without diabetes, and to slow GFR decline with or without diabetes. These agents are not currently approved for type 1 diabetes. Next slide, please. Over past 5 years, the number of annual prescriptions of these agents have gone up from 7.2 to 15 million. And as you can see on the graph, it is commensurate with each positive trial coming out, and the use is continuously going up. Next slide, please. So now we know what SGLT2 inhibitors are, but why should we as anesthesiologists care about these agents? Next slide, please. It has to do with the risk of SGLT2 inhibitor-associated perioperative ketoacidosis, which goes by the acronym in literature as SAPCA. On the right side is a slide from a study in which they actually looked at all the cases of case reports of SAPCA from 2014 to 2021. And as you can see, the number of cases has been rising. Next slide, please. So this slide just tells us that SGLT2 inhibition is primarily an insulin-independent effect, works on glucose reabsorption and the downstream effects. Next slide, please. So glucoseuria is the primary driver of glucose control, and it actually decreases insulin-glucagon ratio. and that leads to ketosis. And ketosis also is part of its beneficial effect on the heart. Next slide, please. However, surgical stress, hypovolemia, low carbohydrate intake, cessation or reduction of insulin or other diabetes medications, combined with continued SGLT2 inhibitor use, can further decrease insulin glucagon ratio and can increase the risk of SAPCA. Next slide, please. So the SAPCA can be euglycemic or hyperglycemic. Euglycemic DKA is defined as blood glucose level less than 250 milligram per deciliter. It used to be an uncommon diagnosis, but studies have shown that of the type of ketoacidosis that occurs in SAPCA, euglycemic ketoacidosis is far more common. And whether the acidosis is euglycemic or hyperglycemic depends upon the balance between glucose, urea, and gluconeogenesis. Next slide, please. Symptoms of SAPCA are similar to symptoms of DKA. It's just that in perioperative period, these symptoms may be non-specific and overlap with usual postoperative symptoms. These are the diagnostic criteria from ADA. Urine ketones in patients who have perioperative ketoacidosis related to SGLT2 inhibitor use are unreliable for two reasons. One is that in DKA, predominant ketone is beta-hydroxybutyrate and not acetoacetate. And also, there is increased reabsorption of ketones from the urine because of action of SGLT2 inhibitors. So the gold standard is to measure blood levels rather than urine ketones. And the treatment is insulin IV or insulin plus dextrose, depending upon if the DKA is euglycemic DKA or hyperglycemic DKA. Next slide, please. So high risk of SAPCA, as you can imagine, will be in surgeries which have higher surgical stress, like cardiac surgery, a prolonged low carbohydrate intake, like bariatric surgery or colonoscopy, procedures which need bowel prep because that combines hypovolemia with low carbohydrate intake, like colonoscopy and bowel surgery, and higher baseline insulinopenia, because obviously we are talking about impaired insulin glucagon ratio. So patients who have higher hemoglobin A1C levels, patients who have need for exogenous insulin or baseline higher need for SGLT2 inhibitor dose have a higher risk of SAPCA. Next slide, please. So this is an estimate based upon 15 million prescriptions that are written per year as of 2020 for SGLT2 inhibitors. And SAPCA is just a subset of SGLT2 associated DKA. And this is based upon an estimate of 0.18% incidence on the RCT meta-analysis, as well as the case series. But in the case series, they also, the authors noticed that many patients were actually unaware of risk of DKA who were on SGLT2 inhibitors. And when patient did present with, come to the hospital, providers initially overlooked the diagnosis. Next slide, please. So this study is the number of cases which have been reported till 2022 by Seki et al. And they found that the most common surgeries were bariatric surgery, CABG, and cholecystectomy. 25% of patients presented on day one, and 11% of cases, it occurred intraoperatively. The acidosis tended to be severe with pH, median pH of 7.16, although it may be a selection bias as to patients with higher pH may not have been detected. And 83% of patients had euglycemia. They reported outcomes in 80 patients. 79 patients recovered the treatment, and 1 patient died of complications of surgery. Next slide, please. So now we know about SAPCA. What should we do, and how should we manage these patients who are SGLT2 inhibitors? Next slide, please. So it stands to reason that factors that may improve insulin glucagon ratio should help mitigate the risk of perioperative ketoacidosis. So some of the factors may or may not be under our control. For example, if the patient, we can change the surgery to less stressful surgery, which may not be feasible, minimize cessation or reduction of insulin preoperatively. This may not be feasible and may also be counterintuitive because patients are not eating and we are actually telling patients not to take insulin. The same thing with minimizing carbohydrate intake or hypovolemia. But what we can effect is holding SGLT2 inhibitors prior to surgery. Next slide, please. Indeed, both FDA in their 2022 guidelines, ACC, American College of Cardiology in 2022 guidelines, and most recent ADA 2024 diabetes standard of care currently advise that SGLT2 inhibitors should be held 3 to 4 days prior to scheduled surgery. This is based upon their approximate half-life of 11 to 13 hours, and the regulatory societies recommend we hold these inhibitors for about 5 half-lives. Next slide, please. However, the current guidelines by these societies do not address how to proceed for patients who did not hold their SGLT2 inhibitors or who could not hold because they're coming for an urgent surgery. And since the surgical stress and the time for which the patients hold their carbohydrate intake and hypovolemia is different, so withhold time should not be same for all surgeries. And the million-dollar question is that should patients without diabetes also hold it for the same duration? Next slide, please. So in 2022, Australian Diabetes Society and New Zealand societies, they came up with the guidelines as to how to approach patients who are on SGLT2 inhibitors. They said, well, if the patient is clinically unwell, postpone surgery. If patient doesn't have diabetes, you can proceed, irrespective of duration of hold. If patient is diabetic, but has held SGLT2 inhibitors appropriately, okay to proceed. And they also made a comment that if patient is undergoing day surgery where there is no bowel prep and patient has a short fasting time, can hold just for the day of surgery. But if the patient is clinically well, has diabetes, and SGLT2 inhibitors are not appropriately held, they use what I call base excess and beta hydroxybutyrate based approach. If beta hydroxybutyrate is less than 1, or base excess is more than -5, which means that there is no acidosis or no ketosis, they recommend that it's okay to proceed with day surgery. If patient is undergoing extensive surgery, talk to an endocrinologist and see if the surgery is okay, is safe to proceed. The same recommendations are if patient has ketosis but no acidosis. And they also recommend that if patient has ketosis, it may reflect starvation, and giving insulin dextrose may help. And if patient has ketoacidosis, as reflected by beta hydroxybutyrate more than 1 and base excess less than -5, if there's elective surgery, they recommend postponing surgery and working up for ketoacidosis. And if the patient is undergoing urgent surgery, then you have to weigh risk versus benefit. The reason that they use cutoff of less than 1 instead of using less than 3 is because there was a study in which they looked at patients who are non-diabetic and are fasting for surgery, and they found that the more than 95% of patients' beta hydroxybutyrate levels did not go more than 1 millimole per liter. Next slide, please. So this protocol was just published in the 2024 Journal of Cardiovascular and Thoracic Anesthesia from University of Pennsylvania. They instituted this protocol system-wide, and the protocol was decided by anesthesiologists, primary care providers, as well as endocrinologists. They came together. The protocol is similar to the protocol from Australian Diabetes Society, but a little bit different. They used what we call the risk factor approach and basic metabolic profile, which may be more commonly available. They said if the patient has no diabetes, it's okay to proceed. If patient is diabetic but has appropriate hold, okay to proceed. If the patient is diabetic and has not held their SGLT2 inhibitor appropriately, if the patient is undergoing urgent surgery, they recommend that we should check for beta hydroxybutyrate and anion gap, not the base excess, but anion gap. And if there is no risk for acidosis, proceed. But if there is acidosis, ketoacidosis, then weigh risk versus benefits. But if patient is undergoing elective surgery, postpone surgery unless patient has lower factors for DKA risk and anion gap is less than 12. And the factors that they recommended was if the expected total NPO time was less than 12 hours, low HbA1c, lower blood glucose, no preoperative need for insulin, and no major comorbidities. The authors, in their post implementation for 6 months period, they said that this protocol, although was based largely on risk factors, did cause significant patient dissatisfaction when the surgeries were postponed. They said BMP in their institution generally takes more than an hour, and that led to significant delays. And most surgeries that were canceled on the basis of risk factor approach. There was only one patient who had an anion gap more than 12, and that patient had normal ketone levels. So this is, again, I think the best approach that they could come up with, but still it is not the most optimal approach. Next slide, please. And then they talk about intraoperatively to monitor for DKA, and postoperatively the patient is undergoing same-day discharge. Ensure the patient can tolerate carbohydrate before discharge, and restart SGLT2 inhibitor after 24 hours. And instruct patient to come to ER if they develop symptoms suggestive of DKA. And if the patient is getting admitted to the hospital, then monitor for DKA and give dextrose and insulin if there's prolonged fasting. Next slide, please. So the bigger question is, because the number, does the ketoacidosis occur in patients without diabetes mellitus? We don't know, because there is one study from 2019. There's an animal study in which they gave massive doses of SGLT2 inhibitor to rats and also did water deprivation, and these rats did develop ketoacidosis. On the other hand, Raven et al. Looked at the CVOT or cardiovascular outcome trials, and they did a meta-analysis, and they looked at how many patients developed ketoacidosis if there's no diabetes, and there was only one patient. So time will tell if this ketoacidosis can occur, and then what should we do for these patients. Next slide, please. So next slide, please. So in conclusion, SGLT2 inhibitor-associated perioperative ketoacidosis is uncommon, but a serious complication. Non-specific symptoms, euglycemia, and unreliable urine ketones can make detection challenging. Provider and patient education are paramount. And current advisory about perioperative withholding are inadequate. Most optimal perioperative approach remains unknown. Next slide, please. Thank you.
Thank you, Dr. Gupta, for your presentation. That was interesting. And the next speaker is Dr. Rushakoff.
Thanks. Let me just get this set up. All right. Well, thank you so much for asking me to be part of this as the token endocrinologist in perioperative diabetes management here. I'm going to be talking a little bit about insulin pumps, just to bring you up to date on pumps. I have nothing to disclose other than everything that we talk about today is actually off-label, because there are no official labels or indications for any of these drugs or pumps perioperatively. So what we have is a situation where this equipment is used to manage a medication that's atop of the inpatient danger list. No one knows how it works, but we use it all the time. So in the hospital, it's an especially difficult place because, again, people really don't know much about pumps, and the pumps keep changing. Basically, the pumps are used to take over insulin management in a way that's physiologic. So if we look at this cartoon, we have basal insulin that would be given to manage gluconeogenesis and control that. Insulin that would be given by the pump for meals, for nutritional doses, and with some luck, we're matching the underlying need for insulin. So who's on a pump? Well, most often these are patients with type 1 diabetes. Historically, they were independent patients. They are virtually and literally tied to their pump. And more often than not, they know more than anyone in the hospital or perioperative area about their management of their diabetes, except when they don't know anything about the management of their diabetes. And sometimes it's difficult to figure that out up front, and we have to do that. So for these patients, we assess them up front to see what's going on, whether it's safe for them to remain on a pump perioperatively or in the hospital. So generally, these are the basics there. Historically, we would want the patient to be able to show someone how they can look at the settings for insulin on their pumps, how they adjust their basal rates, that they know how to administer a bolus dose for a meal, they know how to insert their infusion sets or put it on their tube-free pump, suspend a pump for lows, and they have to have their own pump supplies because almost no institution has all the supplies and all the different things for all the different pumps that are out there. But of course, times have changed, and in fact, probably a lot of these don't matter anymore. They may not need to show us settings for reasons I'll mention in a minute, or have any idea how to adjust their basal rate. They still need to know how to give themselves a bolus for a meal, but that may be just about it. They need to know how to put them on, and they have to have their pump supplies. So who shouldn't be on a pump in the hospital and generally perioperatively? Well, someone who has altered mental status can't do self-management, and that's what this is. Pumps are self-management. If they have metabolic instability, they're in DKA or hyperosmolar coma, generally critically ill patients. If they have a procedure that afterwards they're going to have poor manual dexterity, or they can't move their head to look at their pump, then they shouldn't be on it. Obviously, if they have suicidal ideation, if they don't have their supplies, they can't be on their pump. They need to be able to comply with hospital guidelines. And then generally most patients will want to be on their pump, but some just don't. And so that's their preference. If there's a care manager that takes care of it and they're not there, then they can't be on their pump. And it's always up to, at the end of the day, the physicians in the hospital, the anesthesiologists, and so forth, on whether it's appropriate for that patient to remain. So if we just kind of look at the history of pumps, this is putting together what's used for pump settings. So pumps hadn't changed much till just a couple of years ago. They've been the same literally for about the past 35 years. They just kind of get a little bit smaller over time. So for all these pumps, they generally use regular insulin or rapid-acting insulin in the past many years. And you can then put in a basal rate that changes at any different time during the day based on what's programmed in. So you can see for this patient, they have a higher basal rate overnight, and then during the day it's lower again, and then it's programmed to go back up. And this is based on kind of the results of looking at their glucoses over time. We then have their bolus settings where generally you'll use an insulin to carbohydrate ratio for their meals. They would enter their carbohydrate into the pump, and that'll calculate how much they need. There's a correction dosing sensitivity setting. And again, you put in the pump, in most of the pumps, historically, you would put in what the carbohydrate ratio is. You would put in the current blood sugar, and it would calculate the dose. Now, also part of that is looking at insulin on board. So there is this could be programmed differently on different pumps. Generally, it's a decay curve of 4 to 5 hours. And the reason why this is important, the pump will take this into account when giving a correction dose for a high blood sugar. And finally, we would have our targets and types of boluses for meals, which don't do much for anesthesia, but you can, in the pumps, give a single bolus pre-meal, a prolonged bolus, like for a piece of pizza. sometimes dual bolus from before the meal and after the meal. Although it turns out for the new pumps, none of this matters. Just a single bolus of insulin before the meal is the most appropriate. So where have we gone? So these are the pumps that have been there for years and years and years, and almost to a person, people are moving from these to the new hybrid closed loop pumps. So there are now 4 different pumps on the United States market that are hybrid closed loop pumps. And they all work a bit differently. So just knowing one doesn't mean you know anything about one of the others. And some of the pumps you put in the basal rate, some you put in meals. Generally, you have to do something for meals with all of these. They're all integrated one way or another. As you can see, here's a pump. Here's where the infusion site. Here's a continuous glucose monitor here. And it's all integrated, so the pump is continually getting information on what the blood sugar is and making changes. So let's give you a couple examples. So these are the 4 pumps. There's an Omnipod 5. This is the small pump. It's worn. It's a patch that just generally is worn on the arm. And then we have the Tandem t:slim. There'll be a Mbbs version of this, which is much smaller, coming out in the next couple months or few months. And this uses tubing. There's a bionic pump I'll mention, and then the Medtronic one. This is just a printout of what the glucoses and the insulin doses look like on this Tandem pump. On this particular pump, the basal rate is pre-programmed in. And then the thing I wanted to show you is on this line here, because here you can see the basal insulin all during the day. And what you see is the blood sugar starts going up here. The pump starts giving a little bit more insulin there. Blood sugar is coming down here. The pump turns down and then turns off. So there's no insulin being given here. And what's nice is this really reduces the risk for hypoglycemia in these patients. This is just the same printout for an older Medtronic pump where you can see where it turns off, starts giving more insulin at different times during the day. So these are the different pumps again, and I just wanted to go through this and spend a couple minutes. So we have the oldest versions of these on Medtronic. There's a newer one, it's Medtronic 780G. This uses tubing that goes from the pump to under the skin. Again, it's a hybrid closed loop. It uses Medtronic continuous glucose monitoring. And the way this pump works is you program in a basal rate, and so there's a little bit of a learning curve that the pump does and changes the basal rates over time. Unfortunately, the early Medtronic pumps learned at a preschool level, so weren't all that helpful, to be honest, but their newer pumps are a bit more helpful, and the 780G, like I said, has just come out. The Tandem t:slims, now the newer one that'll be coming out, again, it's a tubed pump. Their version from a few years ago had something called basal IQ, so it just turned off as the blood sugars got low to help decrease the risk for lows. Now they have what's called control IQ. So again, that's what I just showed you on the previous slide, that kind of puts the blood sugar to keep it in range. So if the blood sugar goal is 110 and the blood sugars are starting to go up, it will give more insulin to bring it back to 110. If it's going lower, it turns down or turns off, so it'll come back up to 110 to try to keep it in that range. That'll use a Dexcom G6 and now a Dexcom G7 continuous glucose monitoring. Again, the basal is, you program that in, but the pump will adjust the basal, and then we give and if the blood sugars are going up too quickly, it'll actually give little micro boluses to help bring it back down. The Omnipod, the patch pump that's on the arm generally, it's tubeless. In the past year and a half, people have moved to the newer ones that are called the Pod 5. So these are now hybrid closed loop pumps. They use a Dexcom G6, and as of yesterday, they use a new version of the Libre 2 CGM. So these are what are controlling the pump. What's different here is the patient, you can initially will program in the basal rate, and from that day on, that pump doesn't care what you programmed. It slowly keeps changing the basal rate, and at any time, you actually don't know what the basal rate that the patient's getting. because a pump over a period of weeks actually adjusts to what the patient needs. And the only thing the person has control over is actually their meal dosing. The correction dosing, the sensitivity, all that for while the patient is not eating, like during surgery, is controlled just by the pump itself. The newest pump out for a few months is called the bionic pump. It's a tubed pump. Again, it's sort of a hybrid closed loop. It works with the Dexcom G6. This is completely different. This is where things are going to be in the future. The person gets their pump, they enter in their weight, and that's the only programming that's done. There's no insulin programming, and when they eat a meal, they just say it's breakfast, lunch, or dinner, and it's small, medium, large. And this has kind of just been out, and people are just starting to use it. And finally, there's a smaller group of people, and smaller all the time because these other pumps are getting so much better, where it was called looping. They would get open source software off the web, use the different older pumps with CGM. Usually the software to control it on would be on their iPhone, and they would be using this as a way of doing it. This was the original grouping of things that a person would need for looping. Now they don't have all these things, but it still need a couple pieces of equipment. These are the people who are doing this, especially because there's all this the new pumps are, a very intense group of people for the most part. So historically, which means like 2 years ago, we would say that people on hybrid closed loop pumps, when they come in the hospital, have surgery, should have them turned off and put them in to their regular off mode. So it would be turn off the hybrid mode and use it in a manual mode. That would be absolutely the worst thing you can do. In general, patients do well on auto mode, and you already heard about patient satisfaction. You'll have really bad patient satisfaction. And because you don't even know what the basal rate is, if you put them into their original basal rate, that could be completely different from what the patient's getting, and the patient could go really out of control. So we don't do that. We have our patients always sign a waiver so that they know what they're getting into and what they're responsible for and what we're responsible for. They can't give a bolus without supervision, and so forth. Okay, so some key points here. First, is it safe for the patient to use their pump? They have to have supplies, they have to be able to show you some settings, and they have to sign a waiver form. Are they going to be NPO for a long time? And we have to decide what that means. We'll talk about that in a second. Generally, if they're going to have prolonged NPO time, probably more than 8 to 10 hours, and with a procedure, they may need to be on IV insulin. But never discontinue a pump without starting them on sub-Q basal insulin or IV insulin, and maybe contact an endocrine service to follow these patients if you have that. This is a study where you had patients on pod pumps. They're on their basal rate. They just turned off the pod for 30 minutes and then followed the blood sugars. And you can see just turning off the insulin here for 30 minutes led to the blood sugars going higher later. So why am I showing you this? It's because you're all anesthesiologists and you don't see patients out here. Because I can't tell you historically how many times patients would have their pump off from here to here. Blood sugar is still pretty good during that time, but out here, their blood sugar is super high because they've been off insulin for so long. So you cannot just turn off insulin and say, well, the blood sugar is good for 2 hours, because 4 hours later, it's going to be terribly out of control. Okay, so how do we actually manage these patients? And we use, for our pre-op program, patients go to our pre-op program. We use an online program that we wrote, ucsf.logicnets.com, that they use for all the pre-op diabetes patients. And for the pump part of this program, they'll pick out what kind of pump they're on. They'll figure out whether they are able to use their pump or not based on the questions. And as you put in the information, the patient's specific instructions will get put over here that can be given to the patient. Again, is it a short procedure? Is it a long procedure? And so forth. That, again, will tell us whether the patient should be on a pump or not. And then this is fairly generic. I didn't put in a specific pump. It'll, depending which pump it is, I'll give them instructions on what to do. So for some of the pumps, we put the patient into an exercise mode pre-op. Some of them, we put them into a target, change their glucose target to keep them a little bit higher. But we don't change their basal rate with the hybrid pumps, because if you just go in and reprogram the pump and it's still in hybrid auto mode, the pump will still give extra insulin to bring down the blood sugar. So it would be worse than not having it, than doing nothing at all, for sure. And these would be the instructions that we give the patient. If they were on an SGLT2 inhibitor, it would say 3 days before the procedure, don't take that drug today. 2 days, don't take this drug today. 1 day, so we have each drug lined up by the day. So to sum up all this and put it together for you, the key issues for pumps, for any pumps, patients are told the placement of the pump pre-op, so it's an acceptable area outside the surgical field. They have to bring in all their own supplies, never take it off without IV insulin started or basal insulin given. For the older hybrid pumps, you probably wouldn't use the pump if the procedure is greater than 3 hours or 4 hours, if they're not going to be eating for a few days, and if they can't do self-management. If they've been having recent hypoglycemia, we reduce their basal rate to 80% starting the night before. For the hybrid pumps, we feel it's generally safer to continue in their hybrid mode, and it's generally safer to leave in auto mode than to move to manual mode, because again, if you turn it down or off, the blood sugar in the hybrid mode, it'll really reduce their risk for hypoglycemia. And recall that the basal setting on the pump itself that's programmed probably has little relationship to what their real basal need is. Again, just to be specific, the Medtronic and Tandem pumps, we put them into exercise mode the night before the procedure, because that does give them a higher goal to reduce the risk for hypoglycemia. We don't change their basal rate. The pod pump, we put them into exercise mode, or can change the goal actually to 140. We have no idea what to do with the bionic pump, and we'll see in a couple of years. Probably you wouldn't use the pump for a patient who is going to have procedure more than 3 hours. At least that's what everyone talks about. We've had patients who go to surgery and are on their pumps for 8 hours or more and do fine, but there's no data backing any of this up. And again, if they're not going to eat for a long time, that would be a problem. This is the only study on pumps in surgery in some kids. You can see between these two lines on each of here, these are when they've had their surgery. You can see like on this pump where the pump turned off here during the surgery and kept them from hypoglycemia. This is the pod pump, showing all these red areas are the times where the pump turned off. So I think it just shows that there's still an area of some interest. Let me just finish up with two things, since I don't get the chance to talk with anesthesiologists much, and at least apply this to a pump. For patients on ERAS with those glucose drinks, of course, you should never give them to patients. Absolutely never, ever to diabetes patients, period. There's no evidence for any benefit. And if you have pumps, you're giving them a huge glucose load, and the pumps can't really handle that very well. Dexamethasone, if you really need to use it, use the lowest dose. Glucoses go up much later than you're involved with. And for pump patients, the blood sugars will go up, and the pumps have difficulty quickly adjusting to that. So I've gone through this as quickly as I can, and can move on to the next person. Thank you.
Dr. Josh, thank you so much.
All right. So again, thank you, Dr. Kinjo, for inviting me. In the interest of time, I'm going to move very quickly. We're going to talk about the GLP receptor agonists. As far as financial relationship is concerned, I have received honoraria from Merck, but it has nothing to do with the topic I'm going to discuss. And there's no off-label or investigational use of the drugs I'm going to discuss. So very quickly, I'm sure almost everyone who's practicing anesthesia right now must have heard of GLP-1 receptor agonists. They are not really new drugs, but just in the last year or so, these drugs have received a lot of attention within the anesthesia community. As you can see from the slide, these drugs were approved for type 2 diabetes in 2005, and then for weight loss in 2014. They have significant benefits with regards to cardioprotective effects, as well as some anti-inflammatory response downregulation. There are some side effects such as nausea, vomiting, diarrhea, abdominal pain, and now recently ileus, which typically peak around 8 to 12 weeks. There are many different types of drugs, or the brand names you see here, and its use has significantly increased in recent years and will further increase based on this study, and there are similar large studies that have shown that use of the GLP-1 agonists improves patients' cardiac status, in the sense decreases cardiac complications. This study, which is more than 8,000 patients, almost 9,000 patients, a long duration study, also reported incidence of nausea, vomiting, diarrhea in about 16% of patients using semaglutide. So what's the interest within anesthesia? About last couple of years, there's been reports of increased incidence of regurgitation and aspiration in patients who are using GLP agonists. There are several published anecdotal reports, plus I have a lot of, since I published the ASA guidelines, since we published ASA guidelines, we have received a lot of communications about experiences from our anesthesia colleagues with regards to regurgitation and aspiration. So there is no question, it is a real concern. And it has been increased recently because obviously the number of patients using these drugs have increased. The biggest problem is the patients who are using these compounded drugs, where we have no idea how often they're supposed to take. Also, simultaneously, there are reports of increased residual gastric content in studies during EGD, as well as gastric ultrasound studies. I must say, though, that these studies are still patchy, in the sense there are severe limitations of these studies, including the sample sizes being small in most of these studies. We don't know, or the studies don't report the type of drugs, GLPs, the patients were on, how long they were on. And so it's still kind of problematic with regards to most of these studies showing increased residual gastric content. Furthermore, we don't know what's the relationship between the amount of gastric content and regurgitation, and then obviously aspiration. It is assumed that the reason for increased gastric content in these patients is because of delayed gastric emptying, which is part of the effect of these drugs. Initial studies suggested that short-acting GLP agonists, but not long-acting drugs, slow gastric emptying. However, most of these studies used what's called as acetaminophen absorption test, which is not reliable and does not discriminate between gastric emptying of solids versus liquids. More recently, studies using scintigraphy, which is the gold standard, report that there is delayed gastric emptying of solids for up to 16 weeks, though there is some tachyphylaxis. That means the amount of gastric content decreases over time. However, there are no studies that have looked at gastric content beyond 16 weeks of use of these drugs. So we don't know whether the effect of delayed gastric emptying of these drugs extend beyond 16 weeks. Based on the huge number of reports from our ASA members and experiences and reports of regurgitation and aspiration, the ASA Guidelines Committee was asked to develop guidance with regards to how do we manage these patients in the perioperative period. As we stated clearly in our guidelines that the amount of literature is sparse as well as questionable. Nevertheless, the overall recommendation was that if the patients are on daily dosing, then they should hold the drug for the day of the surgery. And if they're on weekly dosing, they should hold the GLPs for a week. In addition, on the day of the procedure, if the patients have severe GI symptoms, then one should consider delaying elective surgical procedure. If there are no GI symptoms, then and the patients have held these drugs as advised, then one can proceed. Furthermore, if the patients have no GI symptoms, but the GLP agonists are not held, then one can proceed with full stomach. Alternatively, you can do ultrasound, gastric ultrasound, and see if the stomach is empty. And if so, one can proceed. More importantly, there has to be discussion between the patients and our surgeons and proceduralists with regards to our concerns of regurgitation and aspiration. Well, when we look at guidance from other societies, as I mentioned, the ASA recommends holding these drugs either on the day of procedure or week before the procedure. However, if you look at the guidance from American Diabetic Associations and others, they recommend continuation of these drugs throughout the perioperative period. However, their interests are in regards to lack of hypoglycemia caused by these drugs and not regarding to the concerns of residual gastric volume and regurgitation and aspiration. Recently, the American Gastroenterology Societies also came up with their paper suggesting that they disagree with the ASA recommendation for holding these drugs prior to procedure because there is no data. And this is the media blurb, which they had saying the AGA does not endorse all patients stopping popular diabetes and weight loss drugs prior to endoscopy. However, the paper they quote for this media blurb, in fact, except for the duration of withholding the drugs, agrees completely with the ASA. The language states that the ASA is correct in the words we've used in our guidance with regards to consider this and consider that, rather than saying, giving a strong recommendation. And they also agree with the ASA to proceed if the patients are fasting and have no symptoms, as well as perform ultrasound. So in other words, they have regurgitated exactly what the ASA has recommended. The only difference between the gastroenterology recommendations and our recommendations is the duration of holding these drugs prior to the procedure or the surgery. So this month's Anesthesia and Analgesia has an article which I have discussed in details the controversy surrounding the use of these drugs. I don't have time to discuss the details because I do really want to keep some time for question and answers. But bottom line, reviewing all the currently available data, those sparse, there is no question that the delayed gastric emptying and the possibility of ileus with these drugs, there is going to be increased residual gastric volume, and thus there is a potential increased risk of regurgitation. So there's also correlation between patients having GI symptoms, such as nausea, vomiting, dyspepsia, etc., and the potential or possibility of increased restal gastric volume. Furthermore, though we recommend gastric ultrasound, please be cautious that there's a possibility of false positive and sometimes false negative results, and false negative results can burn us if because you might think the patient's stomach is empty. Nevertheless, this is the algorithm which I've developed, where if the patients held their drug as recommended by the ASA, and they have no gastric symptoms, then if they have not held the drugs, then do an ultrasound. If they have held the drugs and they have no gastric symptoms, one can proceed. If they have GI symptoms, then you could do a gastric ultrasound, and if the stomach is empty, you can proceed. While if the stomach is not empty or there's any question regarding the inclusiveness, then either one can do rapid sequence induction or delay the procedure. Bottom line is that the concerns are real. What we don't have, the questions which we really need to ask is, how to manage these patients. There are other aspects of rapid sequence induction or trying to use drugs that could promote gastric emptying, such as metoclopramide, proton pump inhibitors, or drugs that increase gastric pH. Use of all these drugs remain controversial, particularly when I see people using drugs that increase pH, PPIs, or H2 receptor antagonists. And recently, just today, I got an email saying we are routinely using Bicitra now. In fact, Bicitra will further increase the volume. And it's not the concern of the pH. Our bigger concern is the increased gastric volume. So trying to use these drugs is really not helpful in this patient population. Similarly, using NG tube prior to the surgery in an awake state also is not helpful because A, it does not reliably empty the stomach. More importantly, patient satisfaction will be impaired. More importantly, please keep in mind that the concerns of regurgitation and aspiration are not just during induction of anesthesia, but also during emergence from anesthesia. In fact, on the slide which I shared with you about personal communication, the case report I was presented with was the patient who regurgitated and aspirated at the time of extubation. So please perform awake extubation in this patient population. The questions which we really need to be answered, hopefully we'll have some data from future studies, is does the duration of treatment influence gastric emptying? In other words, is there tachyphylaxis has been reported in several studies? If so, what is the duration of use of these drugs after which tachyphylaxis occurs and gastric emptying, delayed gastric emptying does not occur? Right now, we have data only for up to 16 weeks, and even for 16 weeks, there is delayed gastric emptying. The other question we need to ask is holding preoperative dose of these drugs necessary? Does it matter? If so, then how long should we hold these drugs for? 1 half-life, which is what the ASA recommends, which is basically a week for patients who are on weekly dose, or 4 to 5 half-lives. The problem with 4 to 5 half-lives is one, obviously, we know that if you stop the drug for 45 half-lives, it will be completely eliminated from our body. However, do we need that drug to be completely eliminated from our body to have the effects on gastric empty negated? We don't know that. You heard about the SGLTs. The recommendation of 3 to 4 days was based on this 4 to 5 half-lives. But the Australian Society guidelines state 1 day is fine. So the concern I have is people who come up with these guidelines are really not thinking. They want the drug completely eliminated out of the body, which may not be necessary, but we need answers for that. And finally, what is the optimal duration of pre-op fasting? Should we have the patient fasted according to the ASA guidelines or more prolonged? The reason why this question comes up is because the studies that show increased gastric volume or residual gastric volume, the EGD studies, the patients had fasted for appropriate times as recommended by the ASA, and still they had some residual gastric volume. And finally, should the patients be taking liquid diet with the prolonged duration of fasting? So these are the questions we don't have. Nevertheless, this is a big concern. So to summarize, use of GLP agonists will continue to increase because of the significant benefits with regards to weight loss and cardiovascular benefits. There is evidence of delayed gastric emptying and increased residual gastric content despite of fasting. That is really convincing evidence. The evidence to provide guidance for pre-op withholding these drugs and the duration of fasting is sparse and of low quality. So the best approach in my mind, while we get these answers, is when in doubt, one could do rapid sequence induction. And if you're familiar and can do gastric ultrasound, maybe screening the patient's stomach would further help with regards to decreasing the incidence of aspiration. Obviously, we have to discuss our concerns with our patients as well as our surgeons and procedures. Thank you.
Thank you, Dr. Josh and Dr. Rushakoff and Dr. Gupta for wonderful presentations. And maybe I can take one question on the Q&A. What do you suggest for patient on weekly GLP-1 whose last dose was only 5 or 6 days prior to procedure? Dr. Josh?
Yeah, as I mentioned, though the ASA recommends 7 days, that's based on the best guess. It all depends on, in my mind, the symptoms of the patient. If the patient has severe GI symptoms, then there is a concern of regurgitation and aspiration. But one can easily, if possible, do rapid sequence induction and eliminate all the concerns of regurgitation and aspiration. Though one can argue that rapid sequence induction is also not completely proof in the sense even during rapid sequence induction, patient can regurgitate, but the chances would be small.
Thank you. And Dr. Rushakoff, there's a question about Tylenol. Does it interfere with glucose insulin pumps?
Well, Tylenol doesn't interfere with the pumps. Historically, the large doses of Tylenol, vitamin C, were a problem for the continuous glucose monitors. New monitors, the interference is no longer an issue. So, yeah. And just so I could, for the GLP-1s, from the endocrine side, of course, all of us disagree with the anesthesiologists because we don't see there being a big problem. We don't want their drugs stopped for an extended long time because their blood sugars will be high and out of control, and they'll have delayed gastric emptying from their high blood sugars. So I think it's not as straightforward as everyone like to say. And these drugs have been out for 20 years, and we haven't seen a lot of problems in the past. So, we're doing, many of us are doing studies on this, big retrospective studies. It won't be very helpful, I have a feeling. And we need some, prospective studies because, and we're all worried about everyone getting their surgery postponed.
Yeah, but it's again in the perspective, as I mentioned, obviously the ADA and states continue. And I agree that there is a concern of discontinuing these drugs and the associated hyperglycemia. However, there is no question that this is a real issue. Whether the non-anesthesiologists agree or not, it is a real issue, and there is no harm in taking precautions. As I mentioned, it's not about how long should we withhold the drug. It's about what to do with this patient population where there is a concern of delayed gastric emptying. There are so many anecdotal reports. It is a real problem. So we can't blow it off. We do need to do more studies, and in the meantime, be appropriate with patient care. Canceling cases is not the right answer. The right answer in my mind is basically be cognizant of the fact that there is a possibility of residual gastric volume and regurgitation, aspiration, and do the right thing.
Okay, I think we passed 2, and let's continue this dialogue on Doc Matter, and please send more questions if you have on to the Doc Matter. Thank you all the panelists and for IRS hosting this webinar. Thank you so much, and good night.
Thanks.
Thank you.
Thank you. Bye-bye.